In this discussion, we'll be looking at chapter 6 in the Blausen. This is the chapter on bone tissue and the skeletal system. And in this presentation, we'll be taking a look at 6.1, 6.2, 6.3, 6.4, and a little bit on 6.5. There will also at the end be some additional slides that I will provide. We are not covering 6.6 or 6.7 in this semester. So bone, right? And the skeletal system. This represents our second body system that we've looked at in this course. We, of course, looked at the integumentary system. Now we're looking at the skeletal system, and we will soon be looking at joint structures and then the muscular system upcoming. In this chapter, we're going to be focusing on learning not so much about naming the bones. That will certainly be a major objective in the laboratory, but you'll be describing the functions of bones, the different classes of bones. We'll be looking at bone formation, bone development, and then finally how bones repair themselves after fracture. Bones are certainly, as we'll see, a lot more than just a bucket of sticks. We will be naming those bones in lab, but you're going to appreciate how complex and how interrelated the skeletal system is to the other body systems. So the skeletal system is not only the bones, but it's also all of the cartilage that we find connected to those bones or attached to those bones. And all of that makes up the skeletal system. The skeletal system provides a protective framework for our body. And certainly, in addition to supporting our body, also facilitates movement. Let's be really careful. I oftentimes see students say that the skeletal system is moving. No, not at all. The skeletal system in and of itself cannot move. It is the muscular system attached to the bones that allows the movement of the skeleton. So let's not contribute movement to the bones or the skeletal system itself. We'll see many examples where the skeletal system protects internal organs. For example, the skull and facial bones, cranial bones certainly protect the brain. The vertebra protect the spinal cord. The rib cage protects the lungs and heart. We're going to see also that bones are where all of our blood cells are produced. And then finally, bones are a tremendous reservoir of calcium and phosphate. That calcium phosphate mineral content is important for the strength and the characteristics of bone, but also the bone is constantly releasing calcium and phosphate to help maintain our homeostasis. And then finally, the very center of many of our bones contains fat. So it's also a storage place for excess energy. So let's get looking at the skeletal system. In high school, in previous classes, you may have simply named all the bones of the cranium and of the skull. You might have just called that you might have called all those cranial and facial bones the skull, but we will be naming those individual bones in this chapter. So we'll be looking at that, but here's just a diagram of the brain, and we can certainly see that the brain is enclosed and well protected by the skull. In the chapter, the organization brings us immediately to a disorder of the spinal column referred to as scoliosis. We will be looking at this at the end of the chapter. So I'm going to go ahead and just move forward through this section, knowing that we're going to come back and we're going to talk about scoliosis. We're going to talk about kyphosis, and we'll also talk about lordosis at the end of this chapter. We'll skip it for now and come back to it. So in addition to protecting many of our internal structures, the bones are very, very much involved with mineral storage, with energy storage, and with hematopoiesis. Hematopoiesis is the fancy name for the production of blood. There is a significant amount of adipose tissue or making up our yellow bone marrow, and there is a fair amount of triglycerides that are stored in those adipocytes that are stored there. The red bone marrow within long bones is the site, and some flat bones, is the site of hematopoiesis. Note this can also be called hemopoiesis. So I'm going to go ahead and just put a note here that this hematopoiesis can also be referred to as hemopoiesis. We'll just put that over here. But hemo and hemato both mean blood, as you know from our vocab coming up. And so we'll just say that hemopoiesis or hematopoiesis are the same term. Here we're looking at a cut through the head of the femur. The femur is the longest, biggest bone in your body. It is characterized as a long bone, as we'll see here in a moment. And as we cut through the head, we can see that there is certainly in the center of the bone some red bone marrow. That's what I'm circling here. And then in the very center, we see a glimpse of that yellow bone marrow, which would run down the shaft of that long bone. So that's a pretty quick introduction to just simply the functions and the main functions of the skeletal system. Again, protection, storage of minerals, specifically calcium and phosphorus. Not only the storage, but also the release. We'll talk about that quite a bit later in the chapter. Storage of fat, and the site of all of your hematopoiesis. As an adult, all of your blood cells are produced in your bones. So these first couple sections are going to go rather quickly. We'll take a look at 6.2, and that is bones are classified mostly by their shapes. And we'll also look at the different functions of these bones. So let's just take a look at an example of each of the 5 categories of bones based on their shape. I'm going to start with the most obvious one, and that is the long bones. Now, this particular picture, as you'll learn from lab, this is the femur, the longest bone in the body. And these long bones include all of the bones of the appendicular region. So the tibia, the fibula, the metatarsals, the metacarpals, radius, ulna, humerus, those are all considered long bones. And then if there's long bones, there's also going to be short bones. Short bones are a little bit more cubic in their shape. This is going to include the 8 carpals in the wrist and the tarsals in the ankle. Then there are flat bones. Now, flat bones are not necessarily flat. Flat bones are not only the frontal bone and some of the cranial bones, but also, for example, the sternum is a flat bone, as are the ribs. So imagine you have your fingers running along around the frontal bone, or you have it running along a rib, and your fingers really aren't getting any wider as you run along that bone. So those are frontal bones. We'll see that they're made a little bit differently. And then sutural bones. We won't talk about these again, but you know that there are the sutures of the cranial bones. Here we're seeing some of the lambdoid suture, and these little bones that are formed as the big bones come together and fuse. Sometimes there can be a more substantial little piece of a bone. These are random. Not everyone has them. Certainly not as large as this picture suggests, but any sort of extra bone fragment in the sutures is a sutural bone. Again, we won't discuss those again. And then last and final, there are irregular bones. The vertebra are a really good example of this. Also in the cranium, you have the ethmoid bone. That's another irregular bone. And then lastly, there are sesamoid bones. The patella is the most well-known example of this. A sesamoid bone is a relatively small bone. It's derived from the word for sesame seed, so a small bone. But another characteristic of sesamoid bones is that they are embedded in a tendon. And you'll see later on when you look at the knee that the patella is indeed embedded within the tendon, um, the quadriceps femoris tendon that comes across the knee. So as you're learning your bones in lab, make sure you're asking yourself, is this bone belong to is this a long bone? Is this a short bone? Is this an irregular bone? And I think you'll find that it's a pretty straightforward, obvious thing. Note that all of the long bones of the body are in the appendicular region, as are all the short bones. So all of those are in the appendicular skeleton. Flat bones, like I said, really not flat like they're lying on a table flat, but they simply are very thin and they can be curved like the ribs or like the frontal bone. Your scapula is also considered a flat bone, sternum, and the ribs. Make sure you're watching these videos just to get a visual understanding of these different bones. The irregular bones, like they say, don't fit into any of the other classifications. The vertebra are a great example of those, as is the ethmoid bone. And then again, the sesamoid bones, small, roundish bones. Patella is the one that you will know the best, and they are always embedded in that tendon. Great little table here to keep your long, short, flat, irregular, and sesamoid bones straight, giving you examples over here as well. And that is a very quick run through on bone shape and bone classification. Again, these questions will help you assure that you understand the main ideas and some labeling activities here as well. Now let's dive in just a little bit more. Again, some of this you've already been introduced to in the second lab on histology, and you've already seen a little bit more about bone histology significantly in lab and in lecture. So let's start looking at this. We're going to be first looking at the anatomy of bone, the features of bone. We're going to be looking at the bone markings. This will be a major conversation when we get to labs 4 and 5. We'll be learning quite a few different bone markings. You already know a lot about the histology of bone tissue. We will be looking mostly at compact bone. Under the microscope, we're only looking at compact bone. You're also going to learn about a second type of bone called spongy bone. We will look at where those different bone types are located, and then finally we'll look at how bones receive their blood supply and their innervation. As we look at this, let me make this image a little bit smaller. We're going to be looking at a long bone. Again, this is the femur. Let's take a look at this image. And in lab, you'll be asked to know all of these different parts. And so I'll go over this briefly here as either a first introduction or as a review of what you've already seen in lab. In this long bone, again, this is the femur, but this could also just be, this could be the ulna, this could be the radius, this could be even a metatarsal or a metacarpal. Even though those are relatively smaller bones, they are still long bones in their overall organization. What we find externally is on each end of the bone, you see the blue in the diagram. That is what is referred to as articular cartilage. Articular cartilage is just describing what it does. It is where the bone is going to articulate, or where one bone is going to meet up with another bone at a joint space. And we see articular cartilage on both the proximal and distal end of this bone. This articular cartilage, you already know, is composed of hyaline cartilage. So if you looked at it under the microscope, you would see the classic view of the lacunae and the chondrocytes and hyaline cartilage. Remember, cartilage is going to be a completely avascular tissue. Also, around the outside of the bone, there is a layer called the periosteum. That should make sense. Perimeter, around osteobone. So around the bone, all along the bone, there's going to be this outer tissue. Now, if your dog were to find an old bone in the backyard and brought it to you, unless that bone was fresh, the periosteum would not last. It is connective and epithelial tissues and would not withstand. Most likely, what you're going to see your dog dig up and bring to you from the backyard is going to be a bone lacking that outer layer, and the cartilage would also break down. So you would just see straight bone structures if the bone had been out there any time at all. Let's look at a couple other areas of the bone. The two areas on the end are the epiphyses. The shaft of the bone is called the diaphysis, and then there's a middle area called the metaphysis. Now, physis, this root word, means growth. So epiphysis, we know epi means on or upon. So the epiphysis is, quote, on the growth plate. And that will make more sense to us as we look at how bones grow from both the proximal and the distal ends. In the let's look at other things as well. So we see some spongy bone up here. The spongy bone is found deep within the bone. Around the outside of the bone is where you have compact bone. Now, compact bone is the bone that you're more familiar with. That's the one with the osteons, lacunae, lamellae, osteocytes, canaliculi, all the things that you are now trained to understand and see under the microscope. So that is around the entire outer perimeter of the bone. Spongy bone is on the inside. There are two flavors of spongy bone. There is the red bone marrow that we see up here. And then in the center of the bone, along the diaphysis, the shaft, there's a hollow space, and that is filled with yellow bone marrow, which is primarily the fat storage that we talked about. On the inside, right between the marrow and the bone, is a layer of tissue referred to as the endosteum. So endosteum, endoosteum, right within the bone. So endosteum on the inside, periosteum on the outside. That center can be called the medullary cavity. You'll also see it called the medulla as well. So make sure you know the pieces and parts of the long bone, these regions. Oh, a couple more things here. Bone is an extremely vascular tissue, and there are arteries that go into the bone called through the nutrient arteries. There's not just one, there's a couple of these nutrient arteries that penetrate through small foramina in the bone. And so we definitely have a lot of blood flow going in and out of bones. I think oftentimes we're sort of, we think of bones as being these bloodless sticks, right, that support our body. But as we learn more about bone, we'll see that they're highly, highly vascular, suggesting or requiring that there would be blood flow in and out of the bones. Plus, of course, if our bone cells are being made within the bones, there needs to be a sufficient flow of these blood cells out of the bone as well. Up here we see the epiphyseal line. There's an epiphyseal line here. There would also be another epiphyseal line down at the distal end of the bone that's not shown in this particular drawing. And the epiphyseal line is, when it's formed, is evidence that the bone has reached its adult height. If this were a young person's bone through puberty, we would not see a line, but we would instead see a cartilaginous gap called the epiphyseal plate. And we'll see that again in a few minutes as we continue to look at bone. So when I ask you to know long bone anatomy, I'm referring to the anatomy that we just went over on that image. So again, the epiphyseal line versus the epiphyseal plate. Let's make sure we're good with that. So early on, we'll see as we talk about bone development here in a moment, bones grow from their two ends, and bones actually grow from a cartilaginous plate referred to as the epiphyseal plate. and the bone is going to continue to grow longer from that cartilaginous growth plate. But when the bone reaches its adult length, then that epiphyseal plate, that growth plate, will close and become the epiphyseal line. Now, this can happen somewhere in those late teenage, early 20 years. There is a range of this. Some bones go through this earlier than that, some bones will go later. And men tend to have some of these long bones finishing their growth later in life. Women will stop growing taller earlier in life, and we'll talk more about that when we get to just a little bit about hormones and how they influence bone growth. So again, everything I described, the endosteum, the periosteum, the articular cartilage is all here for you. I'm going to skip over this conversation for just a brief moment. This is showing us that in the periosteum, that there is both a fibrous and a cellular layer out here. This is both connective and epithelial tissues. And we can see that right making up the outer layer of the bone itself is the compact bone. And we know what we're going to see, right? We're going to see osteocytes hanging out in lacuna with canaliculi. And we can see here 3 lamella in this picture. And this is also true inside where there's the endosteum. We have these cells. Now, I'm going to talk about osteoblasts, osteogenic cells, osteocytes, and osteoclasts more in a moment. They are introduced here, but there's more information coming about them in a moment. Let's compare that long bone with a flat bone. And so here we've taken a chunk of the frontal or parietal bone, and we are going to see that the architecture of a flat bone is quite different. What we have here now is on the outside and on the inside. So here is, imagine you have the scalp out here, the skin, hair, if you will, on the surface of the cranium. On the inside, you have the brain down here deep to this, but there's a layer of periosteum on both sides. There's a layer of compact bone on both sides. And then there's a pretty good layer of spongy bone in the middle. And this spongy bone middle has a special name called the diploid. So that's a word that's just a specialized word for you to know, but it is the spongy bone found in a flat bone. We won't be talking much, really not much at all, about the development of flat bones. We will talk quite a bit about how long bones are developed later on in this section. Now, one of the things you're seeing in the lab is naming quite a few different bone markings. Some books call these bony markings or bony landmarks in different books. But these are the pieces and parts where really cool things happen and how the bones are allowing blood vessels or nerves to pass through, or where they are allowing a tendon or a ligament to attach. And these bone markings are really important for your overall understanding of how the muscles attach to the bones and how your bones allow for the passage of nerves and blood vessels. There's a whole bunch of terms here. I'm going to wait for lab to be the focus of this, but you have a whole list of bone vocabulary terms that you're learning, and this is essentially that same list. And it gives you the name. So you need to know what a condyle is. You need to know that it's a large rounded surface. You need to know what a process is, what a spine is, what a tubercle is, what a tuberosity is. And here are the short definitions and also an example of each. All of these are part of our laboratory learning this semester. And as we pass through this area here, I'm not going to pause here for very long, but just to tell you that many of these bone markings are, again, the places where tendons and ligaments attach. They are the places where blood vessels can pass through. Down here is the mental foramen. There are fissures and cracks and foramina. There are sinuses or spaces again, that allow for nerves and different structures to pass through. It'll be much, much easier for you to learn your bone markings if you have an understanding of what a process is, what a spine is, what a tuberosity is. It'll help you understand what you're looking for and give you a much better understanding. You're not just memorizing these 60 or 70 bone markings. So let's get into the bone cells that we find in the tissue. You know from lab, one of the first questions you were asked on the lab pre-lab was, what are the main components of bone? And most of you wrote down properly that there is the collagen fibers, that'd be the organic component. Remember, an organic component is something that's made up of proteins or nucleic acids or lipids or carbohydrates. And so we have the collagen fibers that provide a lot of strength to bone. And then there's also an inorganic salt crystal, the calcium phosphate, which, just to simplify it, is part of the hydroxyapatite structure that we find in bone. And there's quite a few things in there. I only mentioned calcium and phosphate, but there's also some magnesium in there, there's some fluoride in there, there's some sulfates in there as well. And it's the hydroxyapatite, the mineral content, that gives bones their hardness, and it's the collagen that gives them their strength with a little bit of flexibility, just a little bit of flexibility so that they're not so brittle. And you know from our histology that the one cell type that you already are familiar with found in compact bone are the osteocytes. But we're going to see here in a moment that there's also osteoblasts, osteogenic cells, and osteoclasts. So let's take a look at all four of these cell types. Here is a great video to help you understand this. So first of all, we have osteocytes. You've learned about osteocytes, you've seen them. They are relatively inactive cells. You've seen them living in the lacunae, those narrow spaces within the lamella of the osteon. But where did those osteocytes come from? Well, before they were osteocytes, those same cells were osteoblasts. Now, you know from the vocab that blast means to form or to germinate or to bud from. So these are actually the bone builders. So think blast for building. So the osteoblasts, as you see in this cartoon, are plump, very active cells. The osteoblasts are the cells very, very busy making the collagen, making the calcium phosphate hydroxyapatite crystals. And when those osteoblasts have already built their lacuna and have already built the bone, then they go into semi-retirement and they become the osteocytes. Now, osteocytes still have a homeostasis. They still need nutrients, but they're less active. Now, where do the osteoblasts come from? They originated from osteogenic cells. These are the stem cells found in bone. Osteogenic, think genesis in the beginning, the production of, the making of. So the osteogenic cells are the early cells. They differentiate to become the osteoblasts. They're busy making the bone. When the bone is built, now those osteoblasts become osteocytes. So these three cell types are definitely related to each other in the same differentiation pathway. Another bone cell, unrelated developmentally, are the osteoclasts. And you know from the vocab that clast means to break down. So these are cells that actively resorb or break down bone. One of the characteristics, well, there's a few characteristics of these cells. Number one, they're huge. So if you look, the osteoclast here in this cartoon is significantly bigger than the other bone cells. The other thing we notice is that this cell doesn't have one nucleus, but is a multinucleated cell. So the osteoclast is multinucleated. This is our second multinucleated cell that we've seen. We also saw that skeletal muscle cells. are also multinucleated. A couple more characteristics, and the artist did a nice job of including that. You see lots of little vesicles inside the cytoplasm of the cell. Those little vesicles are full of digestive enzymes, and they will be releasing those digestive enzymes in an effort to digest or break down the bone. These cells are critical to the release of the calcium and phosphate. And the osteoblasts are helping to build up excess calcium and phosphate. So we see as we go through this chapter that the osteoblasts and the osteoclasts are going to be in a constant battle with each other. As we're young and through most of our life, the osteoblasts are busy building. The osteoclasts, yes, they break down bone, but we don't want to give them a negative connotation. Osteoclasts are critical to maintaining our homeostasis. We're going to see sprinkled through this chapter that the calcium that is released by these osteoclasts under hormonal signals, calcium is necessary for your muscle contractions. Calcium is necessary for your nerve conductions, for your nervous system to work properly. Calcium is necessary for your blood to clot. So there's some very important processes that require large amounts and a constant supply of calcium. We're also going to see, and you already know this, that there's quite a few places in the body where we need phosphate. Remember, bones store calcium phosphate in that hydroxyapatite crystal. And you've already named a number of things this semester that have phosphate or phospho in them. Think phospholipids, right? The phosphate group that is making up those phospholipids found in all of your cell membranes require a constant supply of phosphate. You also have, don't forget, DNA, right? DNA has a sugar phosphate backbone. So there must be a constant supply of phosphate to make DNA and RNA. And don't forget about ATP, right? The P in ATP is phosphate. It's adenosine triphosphate. So there's 3 phosphates in ATP. So again, we see that these are incredibly important atoms and elements within our building blocks of our biochemistry and our homeostasis. So osteoblasts, again, are forming new bone. Osteocytes are mature bone, right? They've already done their building and are hanging out. We see those osteocytes in the lacunae speaking to each other through canaliculi. And where those cells came from were the osteogenic cells. They are the undifferentiated, highly metabolic, highly mitotic cells that are in the deep layers of the periosteum and in the bone marrow. And then those osteoclasts, now they come from a totally different line of cells. They are more related to macrophages in that they are breaking things down. And they are not only releasing calcium and phosphate as needed, but they're also helping to form your bones. Think about it for a moment. How did your femur become a femur? How did it form the head? How did it form the greater trochanter and the lesser trochanter? How did all of your bones become recognizable in their shape? It's because osteoclasts were busy chewing away and basically carving out the bone. So think of the osteoclasts as the sculptors, right? They are helping to carve away and create the foramina and the bumps and the holes and the grooves that one sees on our bones that help them also to be recognizable one from another. So here's a nice little table helping you to break down and think about the 4 different types of bone cells and what they're functioning and basically where they're located within the bone. So compact and spongy bone. We've seen images like this already in lab 3. You also saw it in the histology in lab 2. So we're looking here at, and you'll watch this animation, but we'll look at this image. In fact, let's just jump down to this image. We've seen this one before. And so we're looking at, just imagine we're looking at a piece a section of a big long bone. The outer periphery of that bone is compact bone made up of these individual osteons that run the long axis of the bone. In the center of the osteon, there's a central canal containing red and blue blood vessels, veins, and arteries, as well as nerves. We see the many layers, the lamellae that make up those osteons. And we see here in the artist's rendition the space, the lacunae, and if we were to really zoom in, we would see those osteocytes hanging out in there. The little cracks that we see between these lamellae and going from lacuna to lacuna are the cantiliculi. Deep to that, we have the trabecular bone. That's the type of bone referred to as spongy bone. Quite different than what we've seen in the osteon structure. Under the microscope, we become experts at labeling this. We now know that we're going to see under the bone, we're going to see these osteons. You can see multiple osteons here. And in most of these, we can see a very clear central canal. Notice all the osteons are not exactly the same size. We also see some of the osteons sort of overlapping each other because remember, your skeleton is changing constantly. So these osteons are sort of bumping into each other and rearranging themselves as the bone develops and through years. One structure that I'll point out here that you cannot see in the micrograph are the Volkmann's canals. These are also referred to as the perforating canals. And as you can clearly see here in the illustration, these are perpendicular canals that allow the blood flow in separate neighboring osteons to be connected one to another. So we see blood vessels and nerves traveling also through those Volkmann's canals. You are not going to see a Volkmann canal in the histological images, but you can see all of the other things that I've pointed out. Again, make sure you're interacting with those images and those animations. Now, we are not going to deal with the specifics of spongy bone. I want you to know that spongy bone is also called cancellous bone, and it certainly still has osteocytes, but we don't see the osteons. It's just a different looking structure called trabeculae. You'll also sometimes see spongy bone referred to as trabecular bone because those trabecular are sort of these little spiky arrangements that we see in the spongy bone, and you know that it's found deep to the compact bone. Other than that, however, I'm not moving into learning more about this. We've already mentioned that it's in those trabeculae that we have the hematopoiesis occurring also in the red bone marrow. So we're not going to focus on that image. As we age, we certainly see changes to our skeleton. Our skeleton is changing 5 to 10% every year, and those changes are related to age, they're related to hormonal signals, they're related to deficits in our diet, they're related to how much we exercise. Our bones are kept strong through heavy lifting, through much of our body and being active. And finally, we know that over time, we start to lose bone mass, and that can lead to things like osteoporosis, and we'll talk more about that here in a bit. As we look at long bones, here's another long bone example. We see a tremendous vascular supply that is traveling through the medullary cavity of the bone. Remember, this blood supply that we're looking at in this picture is even in addition to that blood flow going through the osteons in the compact bone. That's not even shown here in this image. We can see that there's a number of places where arteries and veins enter into and out of the bone. We saw that labeled as nutrient arteries earlier, and is traveling through what's called a nutrient foramen, right? The opening in the bone that allows for that blood to pass in and out of the bone. And this particular image is showing an adult bone. Now, how do I know that? I know that because I see labeled the epiphyseal line. I can see the actual line structure here, but even more telling, I see contiguous blood vessels. So this is only going to happen. You're only going to see these blood vessels connected to one another after the bone has reached its adult length and after the formation of the epiphyseal line. If this were a young bone, there would be a cartilaginous plate here called the epiphyseal plate or the growth plate, and these blood vessels would not be contiguous. They would be completely separated from each other because of that cartilaginous border. Remember, cartilage is avascular, and so that is an avascular structure when you still have the epiphyseal line there. Sorry, the epiphyseal plate there. So that finishes up the bone structure section. Point 3, and let's label these pictures, label the osteon structures, and let's get into how bone is formed. We'll also talk about how cartilage is important in this process as well. So your skeleton, not all of it, but most of it, was first formed from a cartilaginous framework. This process of going from cartilage to making bone is called ossification. You'll also see osteogenesis. So osteogenesis or ossification is the process of bone development. This is happening beginning in the 6th to 7th week of embryological life, and your skeleton, most of it, was first hyaline cartilage. Now, there's two ways that bones are formed. One is intramembranous ossification. The other is endochondral ossification. I'll spend most of my time talking about endochondral ossification, but we will briefly mention intramembranous. Again, your skeleton, most of it, was first made of cartilage. So if you were to look at a human fetus in the early, in the 2nd or 3rd month of life, you would see that the bones are not yet bone. You'd be looking at a hyaline cartilage framework, what looks like bones, though, but when you shone a light through them, it would look completely translucent. You also, because it's still cartilage, the skeleton at that point is completely avascular, right? So you see no blood vessels. It would be an avascular hyaline cartilage, very flexible as a result. And then at some point, the cartilaginous structure starts to become bone and is replaced by bone. So we'll first talk about this one called intramembranous ossification. Now, this is the way that your flat bones are formed. Okay, so flat bones, flat bones, flat bones, intramembranous ossification, and flat bones. Okay, and your cranial bones are formed from this type of ossification. We're not going to go into the details of it, but as the name suggests, from within intramembrane, from within a membrane, we're going to make bone. And remember, we have mesenchymal cells. These are undifferentiated connective tissues in the body. And those mesenchymal cells, those undifferentiated connective tissues, will poof, I'm just using the word poof, will become these flat bones. Again, we're not going to go through this piece by piece or step by step, but those mesenchymal cells will gather, start to differentiate, and then different capillaries will start to bombard into those cells and ultimately will form these flat bones. And that's really all I'm going to say, right? That we make this type of bone not through a cartilaginous intermediate, but poof, from connective tissue straight into bone. Where I am going to spend my time, however, is talking about endochondral ossification. And this is the type of ossification where we're replacing hyaline cartilage. This is what we're seeing for all of your long bones, all of your short bones, the majority of your bones. The cartilage does not become bone, but instead the cartilage serves as a template and is replaced by bone. So don't think that this is hocus pocus, cartilage becomes bone, but simply the cartilage is the template and bone is replacing that cartilage. So let's just take a look at the steps here. So we initially have a chunk of hyaline cartilage. Now around the hyaline cartilage, remember this is going to be chondrocytes. This is going to be avascular. It's going to be very translucent. And around that chunk of cartilage is a layer called the perichondrium around the cartilage. Now what's going to happen is that there are going to be some blood vessels that are going to begin to permeate into the diaphysis, into the shaft of that hyaline cartilage template. And with that, these hormone signals and blood that's coming in are going to become what's called the primary ossification center. So we see that bony structures start forming here within the shaft of that template. That will continue, and we see at this point that the head of the epiphysis is 100% completely cartilage. And we see here the eyeballs. So these are chondrocytes living in the lacuna. So this is all cartilaginous at the epiphysis, and we see the bony changes happening here in the shaft. Let's keep going time-wise, and we see the same thing happens in the epiphysis. There will be blood flow coming in. That blood flow brings changes in what is now called the secondary ossification center, and we see the bony changes, the bony formation happening here in the epiphysis as well. Notice that there's bone now in the epiphysis, there's bone in the diaphysis, but there's still a cartilaginous plate in between. This is that growth plate. Even in a young person's bone, right, we have this complete hyaline cartilage surrounding and separating the epiphysis from the diaphysis. Again, that is that epiphyseal plate. Eventually, right, when the bone receives the right signals, this cartilaginous plate will shrink, and eventually this cartilaginous plate will become the epiphyseal line, and these blood vessels will then become contiguous. Bone will then meet bone, and you'll form one bone. Before this, if you were to find this bone in the backyard and give it a few months, the cartilage would break down, and you would find the diaphysis of the bone sitting completely separated from the epiphysis of the bone because they are not yet fused as a single bone. So that's one way that anthropologists can describe the age of a skeleton. When they find it, they can look at the collection of bones and see, have all the bones fused? Have they all formed their epiphyseal line? If that's the case, we know this is a 20-plus-year-old skeleton. But if we find evidence that some of the bones we have a separate epiphysis from the diaphysis, then we know this was a younger person's bone. We look at the relative length, the relative timing, and we can tell the estimated age at the time of that younger person's demise. Now, I'm not going to go into the different zones, so don't worry about the zones, but I do want you to see that, oh, we're going to make that not yellow, but sorry, make that blue. We're going to make this whole area the dark blue, meaning don't focus on it. And so just know that in this zone, we're going to go from good old chondrocytes, right? Good old chondrocytes in the cartilage. And as blood begins to come through, we're going to replace that with the osteocytes, but we're not going to worry about naming the layers. of the process. So let's also cross off all of this. But we will say when the chondrocytes of the epiphyseal plate cease and the bone is completely replaced, and now we have the epiphyseal line. So that line is important. On a long bone, like the femur, we'll have growth plates on both the ends of the bone. We'll have it between the diaphysis and the head, also between the diaphysis and the greater trochanter. And then on the distal end, there'll also be another growth plate. So we see here that bones are growing longer as well as wider as they grow. So again, bones are going to grow longer. They're going to grow longer from their epiphyseal plates. And bones are also going to grow greater in diameter. This kind of bone growth is referred to as appositional growth. So appositional growth is growth in diameter. Let me just focus on those words. Growth in diameter, yellow, appositional growth. Your bones are remodeling throughout your lifetime. No surprise, right? That your bones are elongating and getting longer and stronger and thicker as you grow from a young child to your teenage years and your adult years. In adulthood, we are in largely a homeostasis, an equilibrium between growth and breakdown. And as we get older, mineral changes, hormonal changes, aging changes, then we start to see more negative effects. The osteoblasts will become a little bit less active. The osteoclasts will continue their degrading process, and that can lead to old bone being destroyed. We can work on our diet to decrease this rate of decline. We can also do exercise. We know that doing weightlifting and activities is extremely important for bone remodeling and for bone growth over time. So that brings us to the end of the bone formation, the bone development section. And we only now have one more section on fractures. So if you've ever broken a bone or know someone who has, you're probably aware that when bones break, they will heal. What we go to the doctor for, if we have a significant fracture, is we just want to put those two ends of the bone back together so that their natural healing abilities occur and that the restored bone is in the right orientation, right? If we don't go get the bone set, put into a cast, then the bone may fuse back together at a funky angle, which would decrease function and purpose. Now, we're going to talk about a couple of different types of fractures. There's far more than I'm going to describe here, but I'll get us started in understanding a few different types of fractures. So let's take a look. We're going to look at a table here in a moment. We're going to talk about closed versus open. A closed, a bone that breaks and doesn't require surgery to reset it, but we just put it into a cast. That'd be a closed reduction or a closed fracture. If instead we need surgery, we need to go in there, open up the bone, reset it, maybe add some screws, add some plates, anything like that, where you are having to do surgery to get in there, that is going to be an open reduction or an open fracture. Let's look at a couple other types of fractures as well. I'll describe them. This video will also walk you through this. So let's start at the bottom. A closed fracture, as I just described, is where the skin remains intact. This can also be referred to as a simple fracture. Now, an open fracture is referred to as a compound fracture. This is, again, when at least one of the broken bones tears through the skin, high rate of infection, and these are definitely going to require some surgical intervention to fix them. Green stick fracture. A green stick fracture is a partial fracture. the bone did not completely snap in half. Remember, bones have some flexibility, and so a green stick is a partial fracture. If you've ever just walked through the woods or picked up a twig, you know that a dead brown twig, if you snap it, right, the whole thing will snap very, very easily. But if you pick up a green stick, a green twig, and you try to snap it, it won't snap in half. It'll bend, it might break a little bit, but it is not going to snap. And so think of a green stick as literally a green twig that when you go to, bend it, it doesn't snap, but it just fragments on one portion or another. An impact fracture, if you can imagine you are driving along and you're in a front end collision of some sort. And as a result, your entire leg is shoved up, impacted up into your hip. That could cause an impact fracture where the neck of your femur would break and you would have an impact fracture, as an example. Comminuted is a fracture where we have many pieces. So normally we think of a long bone just snapping in half, those two pieces, but if there's a shattering or many little pieces formed, that is comminuted. Now that may or may not heal on its own. It may require some surgical intervention as well. A spiral fracture is when basically the bone breaks while the bone is in a twisting motion. So imagine you're playing basketball, you go up, you're doing a layup, and as you come down, you're sort of in a twisting motion. If you came down just wrong, you could cause a spiral fracture of your long bones in your leg. This can be gymnastics or anything where the body's in a twisting motion upon landing. This is unfortunately, though, also a sign of child abuse. If you were to take a young person's arm and with your two hands almost wring out their arm like wringing out a mop, you could cause a spiral fracture in a young person's long bones. And a spiral fracture in the emergency room is oftentimes suspect if the child was not doing something that would naturally cause that spiral fracture. So you might have CPS asking a few questions and looking for some signs of abuse. If you think about a long bone, an oblique versus a transverse fracture, pretty easy to imagine. An oblique is at an angle, and a transverse fracture would be straight across the long axis of the bone. I'll show you some examples of this in a moment and some other PowerPoints. So we'll look at some pictures of those different forms of fractures. And then how does bone repair itself? Very interesting. Again, bone is full in the endosteum. There are some of those osteogenic cells. So those are stem cells that are just waiting for you to hurt your bone, to break your bone. And those bones are also very active during development as your bones are growing longer. So when you break a bone, here we see the femur, and we see a relatively transverse sort of fracture here. It's a big bloody mess. And you first form a hematoma. Hematoma, hema, blood, oma, big blob or structure of blood. So you form the hematoma. Now at this point, those osteoclasts are going to also become very busy. They're going to start chewing up the rough edges of that fractured bone. Those osteogenic cells are going to wake up and form lots of those osteoblasts. And those osteoblasts are going to get busy starting to remake the bone. But even before that, we're going to also have some of those stem cells become cartilaginous. So you see this blue represents a cartilaginous layer. So just like bone is first cartilage and then becomes bone, or the template, you also get a cartilaginous template as the bone is forming. Now, by the time you get your cast off, your bone is probably looking like this, right? The bone is very much on the way to healing. You've got contiguous bone structure, but bone will continue to heal and repair itself for years after that fracture. And under x-ray, you might see a little bit of a thickening referred to as the callus around where that fracture was. So there might be evidence on an x-ray of previous fractures. And so you can actually see that thickening around the edge. But the bone will be, pretty much as good as new, as long as the two ends of the bone have been properly aligned for this natural repair process to occur. So that is the end of what I'm going to cover in Blausen. I'm now going to jump over to a series of PowerPoint slides, and we'll take a look at those as well as part of this presentation. So I've opened up those accompanying PowerPoint slides. So let me just go through this deck of 14 or so slides in a slightly different order, but you have these posted in your Blackboard shell. So just referring back to pictures of the different fracture types. So here we are seeing in this particular picture, let's start off with the complete fracture that we're seeing here. So this is a complete fracture. This we can see is, you should recognize this, right? These bones, the ulna here. And we can see that there is a complete fracture. It's all the way through versus a incomplete, AKA a green stick fracture. We can see here, again, there's different examples shown here. So we can see here that in the femur over here, this is more of an oblique fracture. This one here would be more of a transverse. We can see an impact fracture here. So imagine again the head of the femur, the neck of the femur, of course, is broken off in a major impact sort of injury. Here we can see more of a spiral fracture. And then over here we can see more of the comminuted. We see the shattering of the bone. And that certainly is going to require some extra surgical assistance to clean up those little pieces, but also to assure that there's plates and screws that are going to help bring those two pieces of bone together. I have this in words here, again, transverse, straight across, spiral. The bone is breaking due to a twisting force, oblique, a diagonal break, comminuted 3 or more pieces in that break. If we look at this image, you can get a better understanding of a simple or a closed fracture here of the bone. The tibia has simply broken. It did not break out of the skin. Here we can see that the tibia has gone oblique fracture and has severed through the skin. So this is definitely a compound fracture. It's going to require some surgical intervention. Also a lot more bleeding and a lot more infection risk, of course. And then in the x-ray, you can see the green stick. So the idea that the bone is only broken on one side and is not broken all the way across. So that's your incomplete fracture. At the very beginning of the chapter, I mentioned that there were, I was going to skip over and come back to it. Let's talk about this now, just as an example of something that can go wrong. So as our development occurs, our spinal column, our vertebra, can be perfectly aligned like they should be. However, there can be examples of curvatures that are abnormal. The one that I first presented in the chapter was scoliosis. There's a little video of that at the very top of 6.1. And this is a lateral curvature. This is commonly seen in teenage years and as we grow, and is more common in young girls than it is in guys. But basically, the vertebrae are growing at a rate, and they can't all sit top to bottom on top of each other. And so they kind of go off to an outside edge or an outside curvature. And I'll show you a picture of this in a moment. So that's scoliosis. Let's take a look at that now. So here is scoliosis. You can see a S curve, if you will, or a lateral curvature of the spine. You can see how disfigured this is, causing her back muscles to also have some dysfunction. So this can lead to some postural changes, but also some significant discomfort as well. I know a bit about scoliosis. I have it myself. I unfortunately gave it to my daughter, my second daughter, who's an equestrian athlete. and she has a significant case of scoliosis as well. And for her in the equestrian world, it actually did a couple things. When she was on her horse doing dressage, she was supposed to be very, very straight up and down, and sometimes the judges would note her scoliosis, thinking that she was crooked, and well, she was, but in her mind, she was straight. It was a physical deformity of her spinal column that lost, would have a couple points deducted from her scores. She also went into medicine and chose not to go into something that was where she'd be standing for long periods of time, because the scoliosis in her case does cause some back pain and some discomfort. So she knew she wouldn't want to be a surgery hovering over a patient for a long time because of the discomfort. So she chose emergency medicine for many reasons, but one of which she was constantly moving and less likely to have issues with her scoliosis. Another type of spinal deformity is kyphosis. Kyphosis is an exaggerated thoracic curvature, hunchback or humpback sort of look. And this is more common in the elderly. In fact, you'll see this become so significant that the person is always almost looking down at the ground, right? So, how do we slow this down? We can exercise more. There's some braces and physical therapy that can slow this process down, but this is definitely more common in the aged. And then lordosis is more of a lumbar sway back. This is more of a lumbar exaggeration, and this is more common in pregnancy. This is also far more common in obesity. And the solution to reducing that stress on the lordosis is to have the baby or lose weight, and that will reduce that pressure on that lower back. This lordosis can also lead to pinching, as the nerves coming out through those intervertebral foramina are pinched, and that can lead to sciatic pain because the sciatic nerve comes off around L5, S1, L4 area, and so that sciatic nerve can get pinched pretty significantly in lordosis. So those are described here for you. I mentioned that our skeleton undergoes its formation in our teenage and our puberty years and into the early adulthood years. It turns out that females actually go through this process earlier in life, that the estrogen surges that occur with menses and with puberty actually cause the epiphyseal plate to close. So the estrogen spikes that occur in women stimulates a shorter stature, because they will be typically between 10 and 12 when menses begins. And on average, women are going to reach their adult height within 18 months of the onset of their menstrual cycle. Whereas guys, when they hit puberty in the early teenage years, their testosterone surges are actually going to stimulate greater cartilaginous growth at the epiphyseal plate, and that's going to cause a lengthening of the bones. And so we see women reaching their adult height earlier, the epiphyseal plates close, the epiphyseal lines are formed, whereas in guys, the testosterone causes a rapid growth in the long bones, and this can continue even into the young 20s. While most guys are done growing by 17, 18, some guys are known to grow longer into their early 20s. So that's one. Certainly the hormonal effects, male versus female, have a lot to do with how our bones grow. I thought this was a cool picture just to show you. This is an example of osteosarcoma. So sarcoma is a cancer, a tumor, but this is a bone tissue. So when we look at the skull, we see all these spiky areas. This is abnormal bone growth. So this is a bone growing out of control, causing this very unusual bone structure and formation. You can imagine how painful this would be as that bone is growing and stretching the muscles and the tendons and the nerves on, in this case, the skull. So osteosarcoma, a type of cancer of bone tissue. I mentioned the epiphyseal line. Here is a really nice side-by-side view. We have an adult femur, and we have a young person's femur. And you can see that there is a distinct crack, if you will, at the epiphyseal plate. And again, if this bone were found in the, these parts will be separated. So the head of this femur and the greater condyle, or the greater are separated and would be found separate if they were found side by side. Whereas in the adult, we see a fusion of these structures and the epiphyseal line. If we could look internally, we would see a contiguous blood supply between the epiphysis and the diaphysis. Here's another good example of that. Here is, let me start in this picture. Here is a 9 month foot, x-ray of the foot, 2-year-old, 3-year-old, 5-year-old. And is it any wonder that you can squeeze a child's foot into a small shoe and the kids don't complain too much about it because, one, they're not walking much, but also their bones are not yet fused together, right? You can see that the metatarsals and the phalanges are not yet fused together. You can also view, if you look, and here's just a couple I'm going to circle, you can see the growth plate right here, right? You can clearly see the growth plate here. You can see it here as well. You can see it here, right? So as you look around, you can really see that growth plate in these young bones. Even the tarsals have not yet fused. But as we get to adulthood, we see now that the bones have elongated, they've met each other, and we can actually see a line. You no longer see a gap. Now, the gap you're seeing in these x-rays is not the epiphyseal plate, but this is the actual joint space. So we're seeing a nice, smooth joint space between those bones. So those are some synovial joints, and you would expect a synovial membrane around those, and you'll learn more about those in the next chapter. This PowerPoint also reminds you of the microanatomy or the histology of bone, and you've already been through all this, but this is a really nice scanning electron micrograph of an osteon. So now you really get a sense of the depth of the osteon. So we're so used to seeing the 2D flat image of the micrograph, but here we can see the depth of that central canal. You can see the depth of those lacunae. You can imagine an osteocyte hanging out in those spaces. 2 words that I think you already know, and a third word that I want you to learn, and that is, what are tendons and ligaments? You already know that tendons and ligaments connect bone to muscle. You've already heard that ligaments are connecting bone to bone. And you know that tendons and ligaments are made up of exactly the same kind of connective tissue, that is dense, regular connective tissue. You can almost picture it in your mind. When I say dense, regular connective tissue, your mind should go to the histological view of that. But there's another type of tissue called an aponeurosis, and these are structures that connect muscle to muscle. Aponeuroses are also made up of the same stuff. They are also made up of dense, regular connective tissue. Aponeuroses, though, usually don't appear as ropey-like structures like tendons and ligaments, but appear more as flat structures. You will see a couple aponeuroses in lab 4 and in lab 5, but they connect muscle to muscle. And the last slide in this little set of extra slides is the last one. And this is a reminder of the kinds of questions and the kinds of thinking I want you to be doing moving forward. So we are learning each of our body systems in isolation. So we learned about the integumentary system. This week it's skeletal system. Next week it'll be muscular system. After that it'll be the nervous system, and we'll go through all of the body systems this semester. But you also know that our body systems work together to maintain our homeostasis. And so I will be asking you on exam 2 and every exam thereafter about connections between the body systems. And here are some examples. And you will need to write these out, short answer, on the upcoming exams. Exams 2, 3, 4, and 5 will all have connection questions. So for example, let's just think about some things I've already talked about in this presentation where the skeletal system is connected to or related to other systems. So you learned back in the integumentary system that UV radiation hitting the skin, that vitamin D begins its synthesis in the skin. And in that conversation, briefly, you learned that that vitamin D was important for the absorption of calcium into the bones and also into the digestive system. So there's a connection, right, between the integumentary system because we're making vitamin D, and vitamin D is important for calcium availability and calcium absorption for bone growth. You also very obviously know that bones and the skeletal system are connected to the muscular system because muscles attach to the bones through tendons and through tendons, and the muscle contractions move our skeleton. You've seen in the osteon that there are in the central canal and in the Volkmann's canals, there are nerves that travel through the osteon. You've also seen evidence that bones have different foramina, which allow nerves to pass through. So we know that there's a lot of connection between the nervous system and the skeletal system. And let's not forget the most obvious one, and that is that the bones of the cranium and the face protect the brain, and our vertebrae protect our spinal cord. I mentioned briefly about how estrogen and testosterone affect bone growth. So that's a connection with the endocrine system. Cardiovascular system, again, you've seen hematopoiesis occurring in the bones, and you also know there's lots of blood flow going through long bones. The lymphatic system is your immune system, and much of your immune system is originating in the bone marrow where those bone cells and hematopoiesis is occurring. I mentioned earlier that vitamin D is important for calcium absorption in the gut through the digestive system. The ribs and the sternum are certainly protecting your respiratory system. The kidneys are filtering your blood and helping to maintain your normal calcium levels, and your kidneys are protected in part by your skeletal system. And then finally, back to the reproductive system, we have those hormones. We also have the pelvis providing support to the uterus during pregnancy. Again, calcium during milk production for lactation. So the point is, each of your body systems plays an important role in other systems, and I want you starting to think about these. On exam 2, you will need to know 2 to 3 interconnections or connection questions of how the skeletal system interacts with other systems. You will also need to know 2 or 3 additional connections on how the muscular system interacts. So as we get to the muscular system, you hear me talking about these same interactions, and you will need to start thinking about them. This will be a short answer question. It must be very specific, and I will work with you in class to go over this. I'll mention this in the review sessions as well. But this will be a very important part of your exams moving forward. And during my lectures, I will oftentimes point out these interconnections, and it will be your job to grab those as I mention them or think up of other ones. The connections that you list on your exam must be ones that I have spoken out of my lips or that are directly in the book sections that we've covered. They cannot be from other things that you've discovered online about it. So these must be things that were discussed in our course materials. And that brings us to the end of all things related to the skeletal system.